we tend to have a very European-centric view of non-alcoholic fatty liver disease in children. And I think, as Dr. Singh pointed out very clearly, that this is a problem that occurs in children who may not be overweight by the conventional definition because they are genetically overloaded with risk genes that put them make them very vulnerable to developing fatty liver disease. And so what I'm going to cover today is conditions that cause hepatic steatosis, definition and the natural history of NAFLD as it pertains to the pediatric population, the interaction of genes and environment in NAFLD, pediatric NAFLD, what is the size of the problem? Do we know? And how do we evaluate NAFLD in children? Are there non-invasive biomarkers of NAFLD? And what treatment can we offer for NAFLD? And a lot of these topics were really covered so beautifully by Dr. Singh. And so let me begin with a case presentation. And I found this picture on the internet, but I have an identical patient, a Hispanic child living in New Haven, Connecticut. He's 10 years old, and he eats like this. See what he's eating? He's having these sodas, which is full of fructose, saturated fat, high carbohydrate fat diet. So he has a problem with overnutrition, and his Indian ancestry has endowed him with a lot of genes that make him very vulnerable to accumulate triglycerides in his liver. So my patient was 10 years old when I first saw him, very sedentary. He loved playing computer games, watching TV, and his diet was of high carbohydrate, high fat, high fructose, a lot of sodas. His BMI when he first came to the clinic was 45. He had acanthosis nigricans, type 2 diabetes, dyslipidemia with low HDL cholesterol, and hypertension at that young age. 2 years later, his ALT and AST were increased. Liver biopsy showed Nash with early fibrosis. By 18, he developed obstructive sleep apnea. And his response to intensive counseling about lifestyle, diet, and Dr. Singh emphasized it's not just about weight reduction, it is lifestyle, exercise, reducing television time, really did not achieve any benefits. This young boy at the age of 18 ended up on metformin, ACE inhibitors, and oxygen therapy for his obstructive sleep apnea. And so together, this 18-year-old person has life-threatening disease. And under those circumstances, I did refer him for bariatric surgery. And so the scientific definition of fatty liver is when liver triglyceride exceed 55 milligram per gram of liver tissue. And this is derived by the normal distribution of liver triglycerides in the lean individuals, and 55 milligrams is 95th percentile. So fatty liver occurs in the setting of other inherited metabolic liver diseases. And then there is the one that we are more interested in today, that Dr. Singh alluded to, that is usually, but not always, associated with obesity and insulin resistance. And so in evaluation of a patient with NAFLD, suspected NAFLD, it is very important that due consideration and diligence is paid to other diagnoses that can lead to fat triglyceride accumulation. And these include Wilson's disease. We won't talk about alpha-1 antitrypsin. It's a European disease. Galactosemia in the younger children, fructosemia, cholesterol ester storage disease, glycogen storage disease. We heard from Dr. Kishnani. Cystic fibrosis, again, not relevant in this setting. Mitochondrial and peroxisomal defects, citrine deficiency, lipodystrophies, lipoprotein disorders, A-beta lipoproteinemia, and rarely Weber-Christian disease and Schwartzman syndrome. And here is an example of a secondary disorder that leads to hepatic steatosis. And I've now had a number of young children presenting with hepatic steatosis who in fact have Wilson's disease, and this is copper staining on the liver biopsy. And you can see quite extensive hepatic macro as well as microvesicular steatosis. And this is a real diagnostic catch in the early stages of Wilson's disease, which makes it mandatory to check for ceruloplasmin in the evaluation of these patients. The second example that I want to share with you is the early onset lysosomal acid lipase deficiency Warmin syndrome. It presents with prominent hepatic and gastrointestinal manifestations, hepatomegaly and liver failure, as shown in this child, splenomegaly, persistent vomiting, abdominal distension, and profound growth failure, as shown in this growth chart. And there is adrenal calcification, as depicted in this radiograph. And this is a rapidly progressive and fatal disease, and a few children around the world have undergone successful liver transplants. Lysosomal acid lipase deficiency, it results in fat accumulation in the lysosomes, because it is in the lysosomes where the lysosomal acid lipase is deficient, and that it leads to the accumulation of triglyceride, shown in the bottom panel, as well as in cholesterol esters. So both of the lipids are elevated in the lysosomal acid lipase deficiency. There is a late onset variety, and this tends to present in adolescents and in adults. It leads to shorter lifespan and morbidity. There are prominent hepatic manifestations, including fatty liver, elevated transaminases, fibrosis, as shown in that liver biopsy, and liver failure, as depicted in this explant of a patient who underwent a transplant. Other manifestations include splenomegaly, type 2 hyperlipidemia. It is a rare disease, but its incidence is estimated to be 1 in 40,000. But in evaluating a lean patient with hepatic steatosis, it's worth keeping in mind late onset lysosomal acid lipase deficiency. So what about NAFLD in children, the pure NAFLD phenotype? Usually it presents in the setting of an incidental finding of mildly elevated AST and ALT and or echogenic liver on ultrasound, which might have been performed because there is comorbidity in the form of gallstones or functional GI disorders, and patient may complain of abdominal pain. As the liver enlarges with hepatic steatosis, it stretches the capsule and causes abdominal pain. Patients may be obese or may not be obese, as Dr. Singh pointed out, and importantly, there is likely to be a positive family history of metabolic syndrome and maybe even of liver disease and of liver cancer. And so evaluating a patient with NAFLD, it's important that the other causes are excluded, including alcohol in some of the older adolescents, as we have in the United States. And I'll talk about that, and other toxins such as drugs. Obesity and insulin resistance is a usual common accompaniment, but not always. And on liver biopsy, more than 5% of the hepatocytes are steatotic. Thank you. And Dr. Ludwig described was the first person ever to describe Nash, non-alcoholic steatohepatitis, in 1980. And he described that as clinical pathological condition where liver biopsy was consistent with alcoholic hepatitis, but in whom alcohol intake was denied. And so this is a progressive disease. Non-alcoholic fatty liver disease is not benign, it is progressive. In adults, we know that 1/3 of patients with early NASH progress to cirrhosis, within 5 to 10 years, as Dr. Singh mentioned. And amazingly, in a recent study of 4,000 patients with hepatocellular carcinoma, 53% of patients were found to have non-alcoholic steatohepatitis. This is a staggering number and represents the huge burden of disease imposed by NASH. So the benign hepatic steatosis at some point triggers NASH, and eventually it leads over a period of time to cirrhosis and development of hepatocellular carcinoma, and histologically are depicted these various stages in the evolution of liver disease. And so NAFLD is an interaction of genes and environment and lifestyle. And so the controversial hypothesis by Dr. Neal about thrifty genotypes, now that we've entered the era of individual genome analysis, I think we are going to find that the Indian genomes, and there of course will be many families of genomes in such a diverse country, is going to harbor many, many high-risk genes, I think, for predilection for fatty liver disease. And as many of you know, thrifty genotypes was a hypothesis advanced by Dr. Neal to propose that human beings were designed to deal with scarce nutrients. And so now in the time of excessive calories, this has now become a burden, and the metabolism is not adequately programmed to deal with these excess calories. But importantly, there are genetic polymorphisms. And Dr. Singh mentioned this paper from Yale, in fact, by Dr. Kit Peterson. And she and colleagues at the Dallas Heart Study found that the first fatty liver gene that they discovered through genome-wide association study, PNPLA3. In fact, I was a participant in that study. My body mass index is 22. And you know, my hepatic triglyceride was 35. And I carry that polymorphism. And I think that I'm really quite a representative of how the Indian population is really genetically programmed to develop hepatic steatosis and trigger the sequence of events that leads to metabolic syndrome. And of course, the genes have to work in the setting of the lifestyle and environment, and high fructose diet, high calorie diet, sedentary lifestyles. And in addition to overnutrition, it is important to keep in mind dietary composition, which has really accentuated the development of this phenotype. And so this extraordinary study was carried out by Helen Hobbs's group in Dallas, and what they did was they used MR spectroscopy in 2,000 individuals to measure hepatic triglyceride in vivo non-invasively. And they used MR spectroscopy, and then they stratified the patients according to whites, African Americans, and Hispanics. And you can see that for given degree of obesity, it was the Hispanics who had the greatest amount of hepatic triglycerides. However, the African Americans, even though they had comparable level of obesity, did not seem to accumulate hepatic triglyceride to the same extent. And when they performed genome-wide association study, they discovered that genetic variation in this triglyceride hydrolase, PNPLA3, confers susceptibility to non-alcoholic fatty liver disease. And so looking at these different alleles, you find that hepatic triglyceride is highest when there are this homozygous polymorphisms. Heterozygous polymorphism leads to just intermediate level of triglyceride. Same pattern is replicated when patients are stratified according to different ethnicity, but it is in the Hispanics that the effect is most pronounced. And you know, it is we share this PNPLA3 with the Hispanic population. And I think that that is really certainly one of the contributors to the epidemic of fatty liver disease. And so the pathophysiology is complex, but in the setting of overnutrition, there is a huge surge in free fatty acids. They come from adipose tissue, particularly the visceral adipose tissue, which is a major contributor to free fatty acid influx, as well as dietary triglycerides transported through chylomicrons, and glucose, excessive glucose intake that is eventually converted to free fatty acids. And these free fatty acids are then converted into triglycerides. And so NAFLD prevalence in children is difficult to assess with any degree of accuracy because the problems are of selection bias. The diagnosis is not clear-cut, as I think some of the questions highlighted. We have radiological, chemical, and histopathological means for diagnosis. And other than histopathology, other modalities of diagnosis lack the adequate sensitivity and specificity. I think that the NAFLD prevalence in India is likely to be much higher than the West, judging by Dr. Schulman's study in PNAS that Dr. Singh alluded to. So here are the two studies in the adult population based on ultrasound. They found that 16% of healthy, non-obese, non-drinkers had fatty infiltration in the liver, and this rose to 46% in heavy drinkers, 76% in the obese, and 95% in obese and the heavy drinkers. And this much larger study in the United States essentially showed the same findings about how common this disorder was. So the prevalence of abnormal serum aminotransferase values in obese and overweight adolescents was looked at in 2,450 children between the ages of 12 and 18 years. Obesity was defined as greater than 95th percentile, overweight as greater than 85th percentile. 6% of overweight and 10% of obese adolescents had elevated ALT. 50 obese adolescents with modest alcohol intake, and in the United States, some of our adolescents drink alcohol, amazingly. They had elevated ALT as well. So the prevalence increases quite dramatically from 6% to 50%, even in the presence of modest alcohol intake. This is probably the most important study to give us an insight into the magnitude of the problem, performed by Schwimmer and colleagues in California, and they aim to determine the prevalence of fatty liver disease as diagnosed by histology greater than 5% fat in a population-based sample. And this population-based sample represented 954 children aged between 2 and 19 who had died in car accidents and in whom autopsies were carried out within 48 hours of injury. The results amazingly showed that fatty liver was present in 14%. 1% of children between the age of 2 and 4 had fatty liver disease, and this rises to 15% between the age of 15 and 19. Significant factors were gender. Boys were more affected than girls. But look at the ethnicity. Hispanics and Asians had the highest prevalence of fatty liver disease compared to the African Americans and non-Hispanic whites. And obesity was a risk factor in 35% of the patients. And so ultrasound and MRI scanning has also confirmed the association of fatty liver disease together with elevated liver enzymes, which occurs in up to 50% of the patients. And the radiology in patients who have confirmed NAFLD using ultrasound, CT, or MRI have shown that the gold standard is really the liver biopsy. So investigations for suspected fatty liver disease are listed here, and I think everyone here is familiar with that. And this should be followed by an assessment of abnormal glucose tolerance test to assess insulin resistance, as shown here. And in a pathological study on effect of lifestyle, it was found that 41% of obese and 51% of overweight children had evidence of significant insulin resistance and impaired glucose tolerance. And amazingly, 58% of these children had fibrosis on liver biopsy. Liver biopsy is the gold standard. It clarifies the diagnosis and gives prognosis. It is indicated for persistently elevated ALT which is concerning for NASH. But in response to one of the questions that was asked earlier, keep in mind that up to 59% of patients with hepatic steatosis on ultrasound and normal LFTs have NASH on liver biopsy. And there are two patterns of NASH: type 1 fatty liver disease, which is mainly centrilobular steatosis, inflammation, and Mallory's hyaline, and type 2, which is more common in children, prominent steatosis and inflammation in portal tracts. And this study showed that there was considerable overlap in children between the type 2 and type 1 pattern of non-alcoholic steatohepatitis. A number of non-invasive biomarkers have been developed because obviously we cannot do liver biopsies in children on a large scale, and these have been found to have acceptable negative predictive value as well as positive predictive value for presence or absence of fibrosis. This is the transient elastography, and after fibrosis score of 2 seems to be a good indicator of the extent of fibrosis. And so finally, treatment includes lifestyle change, and including 5 servings of vegetables and fruit per day, minimize TV, computer time, aerobic exercise. A number of trials have been taken in the United States, including metformin, vitamin A, and omega-3 polyunsaturated fatty acids. So on that note, I think that my brief was, is it real? It absolutely is real, I think particularly in the Indian population, since we are genetically very vulnerable to developing fatty liver disease.